one of the cerebrovascular fellows here. I appreciate the help of Dr. Cavernomas, who is also with us here. So Dr. Awad, there are many things to say, but he has made numerous scientific discoveries, including the characterization of subcortical ischemic lesions in the aged. He advanced the understanding of natural history of and biological behavior of vascular malformation of the brain, technical developments in neurovascular and epilepsy surgery. His research has been funded for almost 30 years by the NIH of the US, focusing currently on molecular mechanisms of cavernomas under biomarkers and therapeutic targets, and minimal invasive surgical techniques for hemorrhagic stroke. He's been involved in the MISTI trials, as we all know, etc. His recent discoveries include the relationship of the gut microbiota brain axis in the cavernoma development. He published more than 300 papers, books, chapters. He has numerous papers in Nature, Science, The Lancet. He also served in leadership roles at several of the most respected professional societies, and is the founding chairman emeritus of the scientific and medical advisory boards of the Alliance to Cure Cavernomas. He has received innumerable awards and has lectured all over the world. As I told Professor Awad before starting, his biography can be extended into a book. So I tried to make a long story short, and we'll give him the word to start the lecture. Thank you so much for being with us, and you can share your screen.
Thank you so much, Matthias. Can everybody see my screen?
Yes.
So it is my honor today to speak a little bit about a story that played out over the last 30 years in terms of knowledge developed about a very interesting lesion in the brain that by the end of this talk, hopefully you will look at it differently and with more insight. I really have had the opportunity to use the cavernoma as a platform or as a paradigm to study bleeding in the brain. Many of the biomarkers that we're developing and the concepts and tools for studying cavernomas are applicable to other neurosurgical diseases. The first thing I want to mention is, let me see here how I can advance. To see, okay, here we go. Yeah, the first thing is the disclosures. It's mostly NIH funding with some limited collaboration with the industry focused on the disease, and mostly with grants that we have with industry, business, innovation grants, etc. So this idea that a blood vessel in the brain, like you see here on the right, this is a normal human capillary. It is narrow. It's enough space for it to pass one red blood cell, which you see here, a red cell. And then what happens so that the thing becomes something like this, like we see in the cavernoma, a dilated vessel, a leaky vessel with blood actually exiting outside the caverns. This idea of transformation from the switches that turn into a normal blood vessel into an abnormal one has been the focus of what we're trying to study, because deconstructing this allows us to look at steps to treat the problem and to prevent the problem. So the theme is therapeutic targets to stabilize blood vessels and prevent hemorrhagic stroke. So the mechanistic insight that we gained is based on the fact there are many different types of vascular malformations. This is from the cover of the BNI Quarterly back in the 1980s. And it illustrates the number of vessel abnormalities we all deal with in clinical neurosurgery. However, the opportunity arose with the cavernous malformation to study it much better, because of its Mendelian genetic form in the familial disease. And you'll see the story how the idea of knowing the gene allows us to start tackling the problem. And from learning about cavernomas, we ended up learning more about DVAs. You'll hear about that, about capillary malformations, because they are all linked in the same story. Basically, cavernomas were first recognized as such in the 1880s by German pathologists when they were looking at autopsy specimens, and later surgeons in the late 1800s would operate for seizures and resect a lesion that they didn't really understand that looked like dilated capillaries. Initially, on the gross examination, would look like an organized hematoma, but then when they would look at it under the microscope, this is one such picture by Dandy in the 1980s. The knowledge basically didn't change at all for decades. Basically, it was this weird abnormality that the surgeons wouldn't know about because there was no MRI scans, and they wouldn't know about it until the patient bled, and they operate for the bleed or at autopsy, and then they'll find this weird thing, and they didn't know much about it. It all changed in the 1980s. And when MRI came along, because then we could see that some of these ill-visualized calcifications on CAT scan can be very well seen on MRI. And then MRI allows us to diagnose and follow the lesion during life, which was a big change, and follow the lesion without operating on it. And I was doing my neurovascular fellowship at the BNI in the 1980s. I was Robert Spetzler's second fellow after Neil Martin. And it was in that time period that we started recognizing it on MRI scans. The next came the idea that in the American Southwest in particular, a good fraction of the lesions occurred in multiple parts of the brain, like you see here, and the familiality was recognized. And we started writing the early natural history studies on the disease and the clinical pathologic correlations. This all changed in the late 1990s when the genes for the familial disease were discovered, and we started to learn about the gene function, which I will share with you today. And we started to understand the disease that when you lose the CCM genes by a mutation, you have a permeability problem. And so it's a permeability disease. We also discovered the concept of somatic mutations I'm going to tell you about, immune response in the lesion, the concept of phenotype rescue, and on the clinical side, the definition of hemorrhage, because, you know, as clinicians, we always would say, well, you know, every lesion has hemorrhage on MRI scan, but yet the patient never bled. So what do you mean never bled, but yet has a hemorrhage? So it is that particular issue that caused us clinically to clarify this, and this became a very important definition for understanding natural history. Then in the last, I would say 10 to 15 years, we've had one hit after the other in terms of breaking the mechanism story and in developing biomarkers and in starting clinical trials for this disease. So I'll try to share all of this. This picture is one you'll see a little bit later, but I thought it's really of historical importance. This is one of the first mice that we created in the lab, where we knocked the CCM gene and we had to do something else to create a lesion. And when the lesion is created, it was amazing to see it in a mouse brain, looking exactly in its complex form like the human lesion. However, we started to see the early lesion and the normal vessels. So the idea here of starting to grade the progression of the lesion was only possible when we could have a mouse model of the disease. The natural history, I want to spend a couple of minutes, is basically very simple. The lesions that had never bled have a very low rate of first hemorrhage. In fact, these are a kind of first or recurrent. If you tease them down into first hemorrhage, the first hemorrhage is less than 1% per year. And recurrent hemorrhages, once a lesion has bled before, the rates of hemorrhages increase dramatically, particularly for brainstem locations that had already bled before. And the idea that you never get a bad bleed from a cavernoma is BS, because you could have a fatal hemorrhage that people think is hypertensive. This is what this patient was said to be, but then we went back to the CAT scan and we saw this, and at autopsy, this patient had a cavernoma. Risk of bleed versus rebleed from a cavernous malformation is very important. So if a lesion had a symptomatic hemorrhage before, meaning new blood on the scan and symptoms, and you follow this lesion forward, the chance of bleeding is very high. It's in the range of 10 to 15% per year, maybe higher if it's a secondary bleed. However, a lesion that never bled before, the risk of first hemorrhage is well under 1%. So then we are talking about a tenfold change in the natural history between a lesion that had bled previously or didn't. So it is extremely important not to say that all the lesions have bled, but to really understand the concept of symptomatic hemorrhage. Now, about 5 years ago, we published this with the Angioma Alliance expert panel, and you would see here all the big names in the field, the radiosurgery folks, the Daniel Rigamonti, the geneticists, etc. And we found at that time usable publications that help us with the guidelines, more than 1,000 of them, and we were able to articulate consensus management recommendations, but none of them were level A. There were 11 level B and 12 level C, like don't do something. So, for example, do not resect an asymptomatic cavernoma. There is a level C evidence for that. Do not do a cerebral angiogram for a cavernoma. There is a level C. So there was a lot of agreement, but the level of evidence is not strong. What do we know about the surgery? The biggest level of evidence for surgery is that if you have a bleed caused by the cavernoma, removing the cavernoma will stop the seizures in more than 90% of the cases, and more than 2/3 of them will get off medications. This is some of the best outcome in epilepsy surgery ever reported. So if you have a cavernoma and the first seizure, and it is the only lesion this patient has, removing the lesion can be argued for to not only eliminate future bleeds, but to really stop the seizures and get the patient off medicine so that they live their life lesion-free and seizure-free. So it is an important concept, but the issue of epilepsy surgery with cavernomas is not always simple. I chose this case because this case is right in the middle between the Broca and Wernicke's area. So the white matter that's underneath the lesion is extremely important to spare, because that would cause disconnection aphasia. And then the lesion itself, the removal is not trivial. Epilepsy surgeons who don't do vascular neurosurgery would not know how to preserve the artery here as you're resecting this, and this is obviously the vein of Labbé. The challenge in the brainstem lesions.
Vision, up, down, smile really wide. You can hear both sides pretty good.
So you can have dramatic outcomes
to the ceiling,
with
close
the
your eyes, touch your nose with your right index finger. And
so you could have dramatic outcomes with the surgery for brainstem lesions, like this lady that looked like this. and she was absolutely normal neurologically 6 weeks after surgery. And we approached this pre-sigmoid retrolabyrinthine, so it's a hearing sparing pre-sigmoid surgery. I love this approach because it's a straight in approach. You're able to look at everything. If you try to go retrosigmoid, you're looking around the corner. And we never approach these through the fourth ventricle, never ever. I try to avoid that unless the lesion is delivering itself into the fourth ventricle. I never cut into the fourth ventricle to remove a lesion. I always go from the side. But anyway, these look like great. And, you know, you hear a lot of lectures that show you 10 of these and 20 of these. But the data, even reported by the best centers, the Lawtons of the world, Spetzlers of the world, everybody, shows that when you operate in the brainstem for cavernoma, the morbidity is about 50%. The mortality remains significant for medullary lesions. You know, these patients can stop breathing, can have cardiac arrest. And we've had patients like this have that in rehab after surgery. So, you know, it is not a pretty story, but obviously the argument, why do we do this operation, is that if you have further rebleeds in that area, the consequences are even worse. So you don't want to wait too long to do it, but you don't want to operate on a person who's totally normal inside the brainstem. Of course, integrating a number of modalities can be helpful, and all of us use them all the time. But we cannot guarantee the patient a morbidity-free surgery in the brainstem. There are cases like this.
Okay, we'll take a few steps. You walk towards us.
You know, this is not the best outcome. This is a Rankin outcome 3. So she is dependent on others. She is able to ambulate with a cane. But she had presented comatose and hemiplegic. This is a familial case. She had had prior surgery here for a thalamic lesion. And this lesion, nobody wants to really operate if the patient is well. But if it's a last resort, this outcome is great compared to where she was heading with this lesion. But what I want to really share with you in the remaining time is, what have we learned about the disease biology? And will this knowledge help us treat CCM? And what are the implications for other brain bleeding? So we will spend a few minutes on each of these. And I'm going to go fairly quickly. The genetic substrate of CCM, so there are 3 gene loci that cause CCM1, 2, or 3. If you live in the American Southwest, 40% of the patients are familial. In the Northeast, they're 20% familial. And the reason for that is that almost all Hispanic Americans of Mexican descent carry a single CCM1 mutation, that is a founder mutation that they inherited from a common founder. So everybody in New Mexico who has familial disease has it. Almost all the people in Los Angeles and New Mexico and Arizona have this. However, if you're from Mexico City, you are not from the Sonora region of Mexico. If you are from Brazil or Argentina, just being Hispanic doesn't make you more prone to this mutation. This is from a Mexican founder in the northern part of Mexico who immigrated to the American Southwest and seeded the US population with this common founder mutation. There is a similar common founder mutation in Ashkenazi Jews, and another CCM2 common founder mutation recently reported in the southern and southeastern American population who are Caucasians. CCM3 is a very interesting disease because it is by far the most aggressive. And we studied CCM3 extensively. They have about 10 times more lesions on the average than the other CCM cases. And their first symptomatic bleed often occurs very early in life. So in the first few years of life. So it's largely a pediatric disease. And look at the age of the first bleed in CCM3 versus the age of first bleed in CCM1 and 2. So most familial cases present with their first symptomatic hemorrhage in the middle years of life, except if you're CCM3. What's interesting and what we learned from careful analysis of this, if you normalize it for number of lesions, the rate of bleeding per lesion year is the same, regardless of the genotype. So the reason they bleed so bad is because they have more lesions. So that was an interesting thing, that in fact, the risk is the same if you adjust it for that. Now, this is the next concept I want to tell you about, and you cannot do this experiment in humans, and you'll know why in a minute. But in mice, we can do this experiment. So Mendelian autosomal dominant disease, meaning you carry one copy of the gene in every cell of your body, and the other copy is normal. What happens if you lose both copies of the CCM gene? So that experiment was done in the early to mid 90s, and then reported in the early 2000s. And basically, it's incompatible with life. So homozygous loss of CCM is incompatible with life, and specifically in endothelium. So if you knock CCM in epithelium or mesenchymal cells, there will be development with some abnormalities despite homozygous loss. But if you knock it homozygously, embryonically in the endothelium, the mouse doesn't even form a heart. So, so it's very interesting. And the fish that loses this gene has what we call a heart of glass. So it's a very abnormal heart, and we can study that fish. The worm that loses the gene has bubbles instead of a digestive tube in the earthworm. So this is biologically a very fundamental gene, because the loss of this gene function completely is incompatible with life. You'll see now why that's important, other than if you have heterozygous CCM, do not marry your cousin. That's obvious, but there are other important implications. The first implication is, why does a lesion form? So Knudsen had reported this in familial retinoblastomas, and the same mechanism is true in polycystic kidney disease. These are autosomal dominant diseases where every cell in the body lacks the gene, but the second cell in the body has normal gene function. In the lesion, both copies of the gene are gone. So the lesion forms because you lose your second copy of the gene in a somatic mutation exactly in that part of the brain where you form a lesion. So the question would then arise, do human lesions in familial patients have homozygous loss? And the answer is yes, we showed this. And then why only in the brain? Since you could have somatic mutations elsewhere in the body, and we don't get cavernomas all over the body. So why is that? And we'll share the answers with you, because these are important questions. But this is the first paper we reported in 2005, where we demonstrated by allelic somatic mutations. We later showed that it actually occurs only in the endothelium of the lesion, the somatic mutation that loses both copies of the gene. And then the group from Duke, with whom I have since become a collaborator, we showed together that CCM1, 2, and 3 lesions have a loss of the second copy of the gene. So what about sporadic lesions, if you're not familiar? So as it turns out, also sporadic lesions have somatic mutations for the same familial CCM genes. So this is how the familial disease taught us to study the sporadic common lesions. So the sporadic lesion is histologically indistinguishable and also biologically indistinguishable, with the exception that there is no germline mutation in the rest of the cells. So the somatic mutations only occur in the lesion. Of course, the chance of having two somatic mutations in one lesion are so rare that almost all patients with sporadic disease form a single lesion. You're not likely to get struck by lightning twice. The only place where a sporadic lesion can form multiple CCMs is around a developmental venous anomaly. And until last year, we did not know why, but I will explain that to you toward the end of the talk. But the fact of the matter is that the biology of the sporadic lesion is the same as the familial lesion. It's just the mechanism of getting the hit is different. So that led us to develop the mouse models. This is the chronic mouse model. Now, in order to develop lesions in the mouse, in the adult mouse, you have to knock one copy of the CCM gene, because if you knock both, the mouse would die. So you knock both, you knock only one, but then the mouse lives only a year or more, and the brain is so small. So you have to do something else in order for the brain to form lesions. And what we developed was a way of having the brain get a lot of somatic mutations. So we knock genes like MSH, which are somatic mutation repair genes, or other oncogenic genes, and that then let the heterozygous mouse form a lesion like the humans. This is the postnatal model, which is interesting. So we have conditional knockout. If we do the conditional homozygous loss of the CCM gene after birth, we bypass embryonic lethality. So the heart has already formed, and if we knock this gene after birth, the cerebellum, which is still growing, will be all like a CCM. So you get a huge lesion. The beauty of this model is that it's very simple. It's a single injection of tamoxifen, and then in a neonatal mouse, and within 3 or 4 days, that mouse will have lesions. Here you have to wait several months. So there are two different models, and they are very commonly used. What we learned from these models is that the more mature CCM lesions are just like in the humans. They have a lot of B cells. Now, why B cells? These are antibody producing cells. So some antigen is triggering that. You wouldn't get B cells in reaction to just blood in the brain. In fact, when we put blood in the brain, we get some macrophages and a few B cells and T cells, but not this intense plasma cells. These are actively producing antibodies. So Ki67 tells us that the lesions are very proliferative. So about 6 to 7% of endothelial cells lining the cavernoma are proliferating, which is not the case in normal human endothelium. You have to count about 1,000 capillaries to find one dividing endothelial cell in the normal brain. But in the cavernoma, 6% of the cells are Ki67 positive. Of course, macrophages you see, but they are usually in reaction to the blood, and there is iron. And iron occurs in two forms. There is the heme iron, which are the iron inside red blood cells. And then there is the non-heme iron, which is stained with Prussian blue or pearl stain. And this iron stain is what causes the hemosiderin ring. This does not cause a hemosiderin ring. Now, in the mouse lesion, we recognize that the earliest lesion is a dilated capillary. So if you were only looking at this, it has no inflammation, no bleeding, but yet occurs frequently in that brain before it turns into a cavernoma, so that the earliest form of a cavernoma in the familial disease is a capillary telangiectasia or a capillary dilation. This should not come as a surprise. In fact, I had written a paper back in the 1990s before we knew anything about the genetics, and we described mixed vascular malformations. This is an epilepsy specimen, and I showed that there was, if we had shown this to a pathologist, he would have said this is capillary telangiectasia, but yet the lesion is actually a cavernoma. And I later was shown by a history buff that this was in fact recognized by Wyburn Mason in a book, Vascular Malformations and Tumors of the Spinal Cord and its Membranes, published in 1943 in the middle of World War II while London was being bombed. And I secured actually a copy of this book. They have it in most of the big libraries of the good universities. And look what he says. He says that cavernous angioma develops from telangiectasis and both may occur in the same case. He observed this in the spinal cord cavernomas. And it seems that there is no justification for dividing these two. So, you know, the biology eventually proves whether these old-fashioned people are correct or not. So the capillary telangiectasia has no hemorrhage. Once it bleeds, it crosses into the cavernoma because you start the inflammation and the proliferation. So what about this master signaling that makes you not even form a heart? So we connected with Mark Kahn, who is a famous developmental cardiologist at UPenn, who was studying the formation of the heart. And he looked at, he was studying a signal called MEKK3 KLF, which prevents the cardiac pad from forming and the heart from forming. And he demonstrated very elegantly in this paper in Nature, which we worked on it with him, that in fact, knocking out the CCM gene results in signaling loss of MEKK3. That's why the homozygous loss will not form a heart. And what's interesting here is that we found the role of this pathway, Rho kinase activation. So let me tell you a little bit about Rho kinase. So if you lose the CCM gene, Rho kinase will activate. And when Rho kinase is activated, that is what causes the endothelium to become leaky and stop forming tubes. So an endothelial biologist at UC San Diego by the name of Ginsberg, with whom now we collaborate very closely, showed that the loss of CCM gene causes the endothelium, even in the dish, to be permeable and to no longer form tubes. And this is mediated by Rho kinase activation. Why is that important? Because if you inhibit Rho kinase activation, you restore normal endothelium even in the presence of CCM loss. So the beauty here is the rescue of the phenotype without necessarily having to change the genotype. So you can have CCM loss in endothelium. If you inhibit Rho kinase, that endothelium will behave as if you don't have the CCM loss. This is the first idea of a therapeutic target in CCM. So let me move to that. Now, we don't have Rho kinase inhibitors approved for human use except statins. And statins, when they are used at high dose, like in atorvastatin 80, equivalent dose, they accomplish the same effect as Rho kinase inhibition. While low dose statin that just lowers cholesterol but doesn't inhibit Rho kinase, it doesn't do it. So the effect of statin is dramatic on CCM. It decreases hemorrhage and decreases lesion formation in the mouse. And this has led to the current atorvastatin trial in cavernomas that we are doing. The trial completed enrollment of patients, and the results will be available next year. The next thing I want to tell you is about the story of this inflammation. So a person in my lab by the name of Shengbin Shi, who is now back in China, worked for about 10 years with me. And what he did is he actually microdissected the plasma cells from cavernomas and looked at the antibodies that they are producing. And he was able to show very elegantly that these antibodies are all clonally expanded, so that basically all the B cells here are reacting to a certain antigen, which we didn't know what the antigen was until very recently, but they're reacting to antigen. You might think it is blood, but it turned out not to be blood. It turned out that the antigen is actually reacting to a cytoskeleton in adjacent neuroglia. So the neuroglia that are damaged, it trigger this antibody response. And this in part explains why CCMs will only proliferate and get inflamed like this in the brain, because there are no cytoskeleton or neuroglia elsewhere in the body. So that's why you could have the gene loss, but don't form cavernomas all over your body. The other interesting thing is that if you do B cell depletion, which is a drug that is used, for example, in chronic progressive MS and very similar drugs for systemic lupus. These drugs that inhibit B cell actually decrease lesion development and hemorrhage dramatically. So that is a possible treatment. It has not yet been adapted to trials because companies own these drugs and they are now studying MS and other markets, and they have not gotten into using these drugs patents to study CCM. This is a very elegant paper we just published 2 years ago, demonstrating that it's the cytoskeleton of neuroglia that are the antigen that triggers cavernomas. So therefore, this is the explanation why cavernomas form primarily in the neuroglial milieu. This is another story I want to tell you. This is a laser microdissection of the endothelium. You see it here, that is done. You could do that to human lesions or to mouse lesions. And we also did it with endothelium that was silenced in the dish. So this endothelium lacks CCM gene or has many cells that lack CCM gene. So is the endothelium in the dish where we silence the gene, and so is the C. elegans when you knock out the gene. So we studied all of those cell lines to try to see if there is anything in common. And in fact, we found two groups of genes that are impaired. One is inflammatory and the other is dysangiogenic. So that is the problem with CCM, is you have dysangiogenesis and inflammation. But then when we look at the early versus late lesion, which we can only do in the mouse, we were able to show that primarily the inflammation and immune response differentiates the very mature lesions from the early lesions. So this opened the question towards biomarkers. And we wanted to say that if you are a pro-inflammatory person, you are prone to inflammation, you would get more CCM, or your CCM would be more aggressive. You would get more CCM if you have familial disease, and your CCM would be more aggressive otherwise. So we tested this hypothesis in a very common scenario, which is relationship to vitamin D level. And as you know, vitamin D level less than 25 is considered a pro-inflammatory state. And in fact, the threshold of vitamin D around 25 accounts for a very, very strong association between aggressive and non-aggressive CCM disease. So that if your vitamin D level is high, you are much, much less likely to have aggressive disease. So this was the very first idea about a blood biomarker of disease activity based on just inflammation, a very rough signal of inflammation. We later got to be very sophisticated and daring with this. So we ended up looking at inflammatory molecules, many of them, not just vitamin D, angiogenic molecules, and permeability molecules. And we looked at those molecules in patients who would bleed in the next year. So we got the blood today, and then we followed the patients for a year, and then looked at what the blood today would tell us about the likelihood of this lesion bleeding next year. And when you look at individual molecules, it's not very strong. So each one of those correlations that are significant, there were like 5 of them or 8 of them who were significant, barely reaches p.04. And if you do Bonferroni correction for multiple comparisons, you would lose that signal. So only VEGF and ROBO4 and ILB were strong enough that they would stand multiple comparisons. But then we asked the question, can we combine these molecules, and would the level of multiple molecules be a better predictor? How the hell do you do that? So there are very advanced statistics to do that. This is the AIC model, or Akaike information criterion. So it takes each molecule and gives it a 1, and then tests all different combinations of the other molecules and with it. And then we'll try to say which one gives you the best predictive criterion. It would be the most red color. So the most red color belonged to a linear correlation of 4 of these proteins. 2 of them are inflammatory, and 2 of them are angiogenic. Isn't that beautiful? So the blood basically reflects how aggressive your lesion will be a year from now, depending on 2 angiogenic molecules and 2 inflammatory molecules. The sensitivity and specificity is so high, it's almost approaching 90% in both discovery and independent samples, that we were able to publish this in Circulation Research and get a very large grant to study this. So this is what that equation looks like. These are the people who would bleed. These are the people who do not bleed. So it is, this is about prior bleeding. Prior bleeding is not as strong. The correlation is in the 60s, but future bleeding is much, much more robust. And you could almost have a level below which the likelihood of false positive is under 10%. So based on this, we collaborated with Bayesian statistics people that can look at these hunch signals in the blood and try to combine them for precise association. So anybody that doesn't know about Thomas Bayes, you're going to be hearing a lot about Bayesian methods for trials and for things like that. And the idea here is that you take the prior probability, you build it in, and you do the model. So in order to do this, I didn't know much about these statistics. We collaborated with the modern age Thomas Bayes, who happens to be one of the brilliant statistics professors at the University of Chicago. And he put a PhD student in my lab to work on his PhD thesis with these biomarkers. Together we got a grant with a 1 percentile score. That's what happens when you got this. And we are going to validate basically and optimize this blood test over the next 5 years. Very quickly here, I know I have about 5 minutes in the formal lectures, and we'll open up for questions. Is that okay, Matthias? Can I just have another 5 to 7 minutes?
Yeah, that's fine.
Yeah, so I just want to tell you a little bit that permeability in the brain you can measure, and you can measure it using a low-dose gadolinium and dynamic imaging for about a minute after the dose is given. And based on that, using what they call a Larson equation, you can calculate permeability in the lesion and permeability in the background brain in milliliters per 100 grams per minute. This is permeability of the gadolinium molecule. And as it turns out, it's a very interesting biomarker because if you take permeability at baseline, it's very broad and it doesn't tell you if the lesion is going to bleed or not. But if you monitor and get permeability at 2 points in time, the lesion that bleeds increases markedly, while the lesion that doesn't bleed or never bled and doesn't bleed again is the permeability is about the same. So basically, an increase in permeability at 2 points in time is a monitoring biomarker of a new bleed in the cavernoma. The other interesting thing is that the background brain of patients with familial disease has increased permeability. Why would that be? That's because they have one copy of the CCM gene. So their Rho kinase activity is slightly higher than patients with sporadic or non-CCM in their normal brain. So the background brain of familial patients is already permeable. And we have studied this a lot and published papers in Journal Cerebral Blood Flow and Metabolism. But if you look at permeability and perfusion, which is flow rate, and combine them with some molecules in the blood, you can have a very, very interesting, almost 100% prognostic and diagnostic association with the sophisticated imaging. So stay tuned for that. That's going to be playing out in the next few years. The other very important one to know, because you will hear a lot about it, is called QSM. And QSM is quantitative susceptibility. This is different from Venbold or SWI, which is basically a black blotch. QSM turns it into a gray signal, which means how much susceptibility there is in there, and you could turn it into a color scheme. And this amount of QSM is measured very precisely, reflects the amount of iron very, very precisely. We did these phantom experiments. So you can tell how much iron deposit there is in the lesion very precisely. And when you take the QSM of a lesion and then you resect the lesion and you assay the iron by mass spectroscopy, the QSM is identical. I mean, you cannot make this up. You know, it's absolutely predicts the amount of iron that there is in the lesion. And in the mouse model, we show that it's really this non-heme iron that stains with pearl stain that is QSM positive, not the heme iron that is made up of red cells inside the cavern. So this is bleeding. The red blood cells get destroyed and you have deposits of iron. That's what generates the signal. So that is an interesting monitoring biomarker, because if a lesion bleeds, you ought to expect to have more iron in it. And that's in fact the case. Stable lesions, look how many of them we did. They stay stable a year later. The iron amount remains the same. But lesions that bleed increase with a threshold of about 6%. So if you have more than 6% bleeding, that correlates with more than 6% QSM change, that correlates with a new hemorrhage. Now, the problem in a lesion that recently bled, it wasn't stable in the first place. So some of it is going to recover, some of it is going to increase, but the rate of increase in QSM is twice as high as the rate of clinical events. So if you monitor QSM, you are able to actually detect a change in a lesion where there is no clinical bleeding. We can do a trial simulations based on that. And if you have to count bleeds like you would do with a conventional trial, you need hundreds of patients to get an effect or many years of follow-up. While if you look at a 30% reduction in QSM, for example, you can detect that with 20 to 25 patients in the group. So that's what allowed us to do the atorvastatin trial. The primary outcome in the atorvastatin trial is QSM change, and it's accepted by the NIH, and it's under review by the FDA to accredit a drug effect based on QSM change. We did this in multi-site trial readiness, and in fact, QSM as well as permeability can be measured very, very well at multiple sites as long as the analysis of the results is done at a single laboratory. So we can do multi-site trials. Now, in the last couple of minutes, I just want to share the latest exciting things. Just you can sleep on them later. This is the gut brain. Why would the gut cause CCMs to bleed? Well, a long story short, you can read about it in the Nature paper, but a long story short is that when you lose the CCM gene with the signal, the cells on the surface of endothelium become highly sensitive to lipopolysaccharide. This receptor TL4-CD14 is highly sensitive to lipopolysaccharides. So if you have gram-negative bacteremia or even a gram-negative propensity in your gut, then your CCM disease is going to be far, far more aggressive. And in fact, you can make that in the lab where you can make the gut more permeable and you can cause more CCMs. So this is giving the gut permeability that increases gram-negative bacteria in the gut. This is the opposite effect, feeding the mice emulsifiers, which cause also the gut to be leaky. Emulsifiers, by the way, is what preserves foods, meat for 6 months or so forth. So if you eat emulsifier food, your cavernoma will be more aggressive. This is a human, so of course we are not mice. So the humans, in fact, also have a very characteristic permissive microbiome that allows them to develop a cavernoma. So if you don't have the permissive microbiome, you will not develop a cavernoma even if you have the gene. So it is a very, very strong effect that is proven also in humans, and this was published in Nature Communication. This is the latest discovery I wanna tell you about, and then I wanna close up with one other idea. This latest discovery was based on the role of a mutation called PIK3CA. This is an oncogenic mutation. It's been associated with more aggressive cancers, but also it's been associated with developmental anomalies in the lung and throughout the body. And as it turns out, if you have a PIK3CA mutation, in addition to CCM loss, the CCM disease takes off like you wouldn't believe. If you only have the PIK3CA mutation, you get more like venous anomalies, but not true cavernomas. And then if you get both, you get cavernoma and venous anomaly. So that led us to look at the developmental venous anomaly story. And in fact, we have shown in an article in 2022 in Nature Cardiovascular Medicine that the mutation in the developmental venous anomaly is the PIK3CA mutation. So that's what makes a DVA form. But then if there is a second mutation of CCM gene, then the cavernoma will grow on the DVA. So that explains why this is a primer for CCM development. The last point before I close is there is commonality between CCM and aging. Not only because we look sometimes at the aged brain and we wonder, are these microbleeds or are these cavernous malformations? So it's not just the appearance on MRI, but actually the biology of aging has been very closely tied with rock mediation and with endothelial cell failure. So we looked at this permeability issue of familial patients with cavernoma. And in fact, older human patients that do not have CCM have high permeability in their background brain, just like the familial cavernoma patients. So that as we age, even if we don't have CCM, our endothelium starts to look a little bit leaky like the endothelium of cavernoma. And then when we look at the genes of the aging brain, it's a huge amount of overlap between differentially expressed genes in cavernomas. We didn't expect that a disease as rare as cavernoma would have 65% common gene differentially expressed with the aging brain. And they are basically the, sorry, I went back. So, and they are basically all the genes we have shown already in CCM disease, matrix metalloproteinase, thrombospondin, KLF, etc. So as we get older, our brain starts to look more like cavernoma brain. So a lot of the treatments and biomarkers we're developing for cavernoma are going to apply for hemorrhagic microangiopathy and bleeding in the aging brain. What I showed you basically is how we can integrate biology across many, many different signals, and that allows us to use one very uncommon disease to study much more common problems. And I want to end by really giving credit for the people in the lab and the clinical research team, without whose dedication and brilliance we cannot do this work. So thank you very much. And I'm going to stop sharing and open it back to see if there are any questions that I need to answer. Thank you very, very much, Matthias and colleagues.
Thank you, Professor. It was an amazing lecture, really, impressive. So I guess we have many questions. I will start with the first one if Dr. McDougall or Dr. Monti don't have one.
I just want to have a comment to start with, Issam. That was one of the finest lectures I've ever had the pleasure of hearing. Just the density of information in that lecture, and just the arc of your career following this from this sort of little peculiar CT anomaly and to characterize it to the extent that you have, and now these further extensions into aging and the biome, it's just phenomenal, just so enjoyable, and just congratulations on really just amazing work. And
well,
so
coming from you, this means a lot, and thank you very, very much for the generous comment.
Yeah. So first of all, a few questions which could lead to discussion. Is it correct to say that sporadic cavernomas are associated with DVAs and familiars are not?
Correct. That's absolutely correct. So this was observed clinically in a paper that I wrote with my former fellow Salim Abdul Rauf while he was with me back in the 1990s. And we showed that in the familial disease, the rate of DVAs is the same as normal patients, and they are not related to the CCM. So you can find a few DVAs in CCM patients, but the CCMs don't grow on the DVAs, while in the sporadic disease, they definitely do. There is another evidence that's very interesting in the radiated brain. The patients who get cavernoma after brain irradiation, if they happen to have a DVA, that's where a lot of cavernomas will form, on the radiated DVA. So the idea here is that the DVA has already primed with one bad mutation. And if you happen to get a second hit that affects the CCM gene, that's when you will grow a cavernoma.
Okay, so yeah, you published a paper on the developmental venous anomalies being a genetic primer for cavernomas. So is it correct to say that the mutation starts in the DVA and then the cavernoma develops?
That's correct. So in fact, we don't have samples of a human DVA without cavernoma, but we have blood of those patients. And the blood of patients with DVA without cavernoma has a signal of the PIK3CA mutation. So they have a PIK3CA mutation, and then they develop a second CCM mutation. That's when they grow the lesion. So when we resected this is an interesting surgical exercise, because this is a Nature paper that could only be published by a surgeon, because we took the CCM lesion, and then, as you do getting hemostasis, there is a branch of the cavernoma that's right there dangling, of the DVA that's dangling. So I took that tiny branch, 1 or 2 millimeters, and I put it in a separate dish, and we looked at the mutation of the vein and then the mutation in the CCM. And that's how we got that Nature paper. So the vein has the PIK3CA mutation. The CCM has that mutation plus another.
Okay, and a question on the same line before Dr. Montes asked this question. So, do you think there's a relationship between this DVA and the effect of aspirin on future bleedings for cavernoma? Because some people are publishing.
Yeah, of course. So the aspirin story is probably real in the sense that if you clog up a cavern, that cavern could expand and bleed. Therefore, aspirin may prevent a first bleed in cavernoma. That, of course, we have to be very careful, because if you have bleeding, aspirin will make it worse. So nobody in North America uses aspirin after you bleed in a cavernoma. In fact, after you bleed, you kind of tell the patient, stop aspirin for a couple of months, and then we restart it. But all the data is based on first hemorrhage risk, and if you look at second hemorrhage risk, it's basically favors that you put the patients on aspirin that you think are not going to bleed, so they don't bleed. But I think there is a truth to the fact that lowering perfusion in a cavernoma could protect from bleeding.
Okay, it could also be related to some anti-inflammatory effect of aspirin, right?
Also could be anti-inflammatory as well. So you've got the proponents of the perfusion theory, you've got the proponents of the inflammatory theory. There is probably evidence for both.
Okay, Dr. Monteith has a...
Thanks once again, Dr. Awad. That was a real tour de force, just reiterating what Dr. McDougall said. It was very enjoyable. A practical question. You mentioned the changes you get with radiation and radiation-induced cavernomas. Do you use radiosurgery at all? And in light of what we were just talking about in terms of pressure and flow dynamics, do you utilize propranolol in the clinic? So radiosurgery and propranolol, are those
Sure.
your armamentarium?
Yeah, so let me talk first about radiosurgery. So radiosurgery, as you know, has been shown in many, many studies. They're not controlled, but there are multiple studies that the rate of hemorrhage from a cavernoma that had bled repeatedly prior to radiosurgery decreases after about a year or two of radiosurgery. And some people, of course, the skeptics would tell you that that's the natural history anyway. But the data, if you really look at all the meta-analyses, is pretty compelling. And the expert group looked at it, and we basically said that there is, level 2B, that it could help in lesion that had bled before to receive radiosurgery, except in familial cases. Because familial cases, there have been several reports of new cavernomas forming along the arcs of the radiation. So although you're going to have the ablative good effect where all the rays meet, you're exposing some of the brain to the risk of somatic mutations. And if you've got familial disease, you could actually be creating more lesions. So what the guidelines say is that it's not recommended in familial cases. It can be considered in inoperable cases that have previously hemorrhaged, as long as they are sporadic, which is, I think, the common practice out there. Most of us would take it out if it can be taken out, but a diencephalic 1 centimeter lesion that had bled doesn't warrant going into the diencephalon, but if you radiated it and got it to be quiet, it's probably okay. I do about 2 to 3 radiosurgeries for every 50 open operations for cavernomas.
Yeah, I think I was trained by Dr. Steiner at UVA, and I think it would be fair to say he was a reluctant proponent, meaning that he was aware that depending on how you analyze the statistics and when you started measuring the time of how many years people were before they bled, if you met them when they just started bleeding, and that was the start of the timeline, you could manipulate the statistics. And of course, his wife was an expert statistician. So I found that very interesting.
There's one other factor, if I may interrupt you, has to do with dosimetry, right? So the early CCM series, they radiated them like AVMs, giving 20 GY. Now you would cause disasters with CCM. So what we've learned mostly from the Pittsburgh group is that you need to treat it like an acoustic, 12 to 13 GY. That's all you need to do for a CCM. And in fact, if you go to the high doses, you're going to, the iron can be a sensitizer. And the other issue is the target. If you target the hemosiderin ring, you're probably treating a part of the pons or diencephalon that has no cavernoma, that just has iron. And so I think we treat very conservatively in dosimetry, very conservatively in targeting, and in only very selective cases where you really don't want to operate.
Right. And one final question about propranolol. Do you prescribe propranolol for patients that maybe haven't bled and want to do something but don't want to have surgery?
So there probably is safer to use propranolol than statin until the results of the statin trial, if you want to use something, because people come to you, they read it on Wikipedia, you know. So we have no evidence of harm with propranolol, but the evidence of help with propranolol is pretty weak. So the Italians just published a trial in a phase 2 trial, very underpowered. They had like 3 bleeds in one group, 4 bleeds in the other, and they say maybe there is a hint of benefit. But I was invited to write an editorial which I entitled, it's in Lancet Neurology, I entitled it "Credulity and Exploratory Trials," because they were really milking the data like you wouldn't believe. So there really wasn't a signal benefit in a very underpowered trial. But does it harm? It probably wouldn't harm. The problem with propranolol is that in the mice, it only works when you give a dose that lowers the heart rate and blood pressure. This is where the perfusion effect probably is. So most patients are not going to take 180 milligrams of propranolol. They're going to be dizzy, and so they're going to cut it down to 20 milligrams a day, which probably does nothing.
Good.
Yeah, so in many of those, one of those Italian trials also had like the doses of propranolol were not standardized.
They were all over the place.
All over the place.
The other thing that we pointed out in the editorial is that they said the number of patients with bleeds was cut in half, 3 versus 6. And of course, it's not statistically anything, but one of the patients on propranolol had 3 bleeds, and they counted those as one patient bleed. They had 3 separate bleeds month apart on propranolol. So that alone would make it no effect at all. So I just don't see an effect so far. But if you could tolerate high dose propranolol, maybe it'll work. Now, there is a lot of work going on to see whether metoprolol or another beta blocker that can affect the actual beta blockade without the intolerable side effects of high dose propranolol may help. So, but it's not there yet.
Okay, another question, Professor, regarding the brainstem cavernomas. So we all know from the classic literature that they have like a higher bleeding risk. Do you think it's because of maybe the eloquence of the tissue is like more symptomatic, or there is a different biological?
It's interesting. What we learned from the QSM is that the rate of increase in QSM in lesions is about the same in brainstem, non-brainstem. The bleed is much more likely to be symptomatic in the brainstem. So I think all lesions probably bleed at the same rate, but if you're sitting next to the oculomotor nucleus and you have a tiny little bleed, you're going to have a diplopia and it's going to be counted, while it won't be counted if you bled in the occipital lobe and got a migraine.
Okay, and another question regarding follow-up. What is your follow-up strategy for familial cavernomas versus sporadics?
Yeah, so this is one area we couldn't agree as experts. The guys from England said, don't follow anybody. When they get a problem, they'll come to you. What I find in my practice that is useful to follow are 2 points. Patients are doing all kinds of things in their lives. They get on ADHD medication like dextroamphetamine, Adderall, and now we know that causes bleeds. They take women take birth control pills that causes bleeds. So low vitamin D. So it's nice to be able to reassure the patient, your lesion is fine. You have a scary lesion in the medulla, but nothing happened this past year. Everything you're doing is okay. And it's interesting, when they have a bleed, we often look back and there are triggers. Some of them started probiotics, which could have affected the microbiome. Many people had COVID and then bled. Many people have a UTI or prostatitis in the males, and then their cavernoma bleeds. So it's in my practice, I monitor most patients every 1 to 2 years while they're asymptomatic, just to really be sure nothing bad is happening. And for the familial cases, you can count their lesions and tell them they're not forming new lesions. Of course, the counter argument, what the hell you're going to do about it, but we are learning a lot, and we enroll patients in studies, and we're doing biomarkers. So I follow the patients once a year.
Okay. Are you doing these perfusion images and permeability MRI as you publish for patients, or still not in the clinical?
Not in the clinical. It's very expensive because you have to have the research team at the MRI machine. You can't tell the radiologist, do that for me. The data will be useless. So I send basically bioengineer and another person to be there. The good news is that it only adds about 4 to 6 minutes to the scan. And it's the same gadolinium dose that we give for the imaging, but we do it in a different way of acquiring the thing. So if you have a team and you're in research, the NIH pays for it, so I can afford to do it. But I don't think yet we have enough to tell you, do it at your place and it's actionable. It's not actionable yet until we have good research tools. The best application for QSM is as a monitoring biomarker during trials.
Okay. There is another clinical scenario that is always in the classical literature, it's often reported that cavernomas that present with seizures have a better overall prognosis.
Not unless the lesion is resected. So actually the story is that the likelihood of having intractable epilepsy from a cavernoma induced seizure is very high. So if you're a 21-year-old and got your first seizure from a solitary cavernoma, the likelihood of heading into intractable epilepsy is maybe about 30%. And then the likelihood that you need to stay on medication all your life is 100%. Those patients, you can never get off medication unless you remove the lesion. So there is a lot of argument to operate for epilepsy-related cavernoma before it becomes intractable. And there we have evidence in the guidelines on that.
Okay, you recently reported a few years ago a few cases of a laser interstitial thermal therapy for cavernoma. What is the state of?
Yeah, so again, it's a mixed story. The laser works very well if the lesion is small. Most laser people will tell you, I'll do something up to 3 centimeters. But basically, if it's a cavernoma that big, you're boiling blood with the laser. You're not really lasering the lesion. But if it's a tiny hemosiderin, mostly lesion, less than 1 centimeter, but a lot of hemosiderin, you can create a hole there. And it has been very, very useful in mesiotemporal cases, mostly on the dominant side, where you don't have to do any damage to the temporal lobe. So we tried it first with the idea that if it didn't work, we'd go back and do the classical resection. And the results were very good. And it also is good in multiple lesions. If you got a patient that has 4 or 5 lesions, and 2 of them are in that bad temporal lobe, epileptogenic temporal lobe, you can burn those 2 lesions and see what happens. And that's not as elegantly done with open surgery. We do a lot more harm to the lobe doing that. So we find it to be complementary. The reason I say it's a cautious story is because there was a report, and our experience is the same. If you laser a lesion that has recently bled, the lesion doesn't go away, and you get a lot of edema from the laser. So if you're doing it because it's in the diencephalon, you're going to do more harm. And so we don't like to laser lesions that recently bled, and we don't like to laser big lesions.
Okay, a few questions from the chat. The first one is if you think that stabilization of tight junction can improve the strategy to reduce bleeds.
Yes. So the only drug we have today on the market that stabilizes tight junction is high-dose statin. That's how pleiotropic effects of statin are. You know, statin lowers your cholesterol, but also helps stabilize the atheroma, stabilize your vessel. And the way it does it is through Rho kinase inhibition. But that requires a high dose, so Lipitor 80, in order to have a Rho kinase inhibition. Of course, the reason we did the trial is because, one, we don't know it helps cavernoma rebleed. And second, there is concern about statin causing more bleeding, right? So are we really harming or helping? That's what the trial will show. And QSM is beautiful in this regard, because even if it didn't cause more bleeding, if it caused the QSM to be going in the wrong direction in patients we gave statin, it will raise concern.
Okay, and in a role for Avastin in that same line of
yeah, the problem with Avastin is that it causes high risk of bleeding.
Yeah, right.
You know, so
Right.
We are using Avastin in hereditary hemorrhagic telangiectasia for nasal AVMs, and it shrinks the AVMs. And there is a trial going on of Avastin for intractable nasal bleeding in HHT patients. But that's different from a brain cavernoma, and it probably biologically will work, but you know, I'd be hesitant to give Avastin.
Yeah. Another question is why do you think that systemic inflammatory diseases can increase the risk of bleeding in cavernomas?
Yeah, so why is that? Because every single gene study we showed that the cavernoma development is driven by inflammatory and immune genes. So if you're prone to this, meaning you have two patients, one of them has more inflammation, that person is going to have the CCM be more aggressive, and we've shown it in different ways. But I want to give you just one example that will make you all smile. You know, the C. elegans, which is earthworm, has no circulatory system. It has a single tube that is both digestive and circulatory, a single tube. It has no white cells, so it has no T cells, B cells, nothing. The gene that's most dysautoregulated after you lose CCM and C. elegans is immune genes. Immune what? You don't even have white cells, but there must be something in fundamental biology that is about immunity, where the white cells help drive it, but every cell has those genes.
Okay, and the last question from the audience is like probably a short summary of how you approach cavernoma in young children.
Yes.
Asymptomatic.
Yeah, so the children have longer time to live with the cavernoma, and there is a reason why you discovered it in a child. So I always wonder how symptomatic versus asymptomatic. So we will watch the kids, and also as they're growing, they're playing sports, they're getting head injury, etc. So we keep an eye on the cavernoma, but the standard for resection is the same as in adults. If it causes seizures and the seizures are caused by the cavernoma, we remove it. If it bleeds or grows, we remove it. Otherwise, we leave it alone. The familial cases, we count the lesions and reassure the family that they're doing everything they can, vitamin D, no probiotics, etc., no birth control pills to help keep the cavernoma counts down.
Issam, I just want to say again, thanks so much for coming. This just so much information. There's hundreds of lectures in there, I feel. So I have to go and digest all of this now, but thank you so much. It was really enjoyable and really informative, and I think a lot of us will be reviewing this one on the website. So thanks so much.
Thank you all. I want to congratulate Matthias and also Steve and you, Cameron, for doing this. This is, I was saying earlier before you all came, I think this is an amazing initiative you guys are doing, because this is available to people in the third world, whatever, that, it's important for them to know how we're thinking if we are at the edge or we think we're at the edge. All right.
Well, you're definitely at the edge of this, leading the charge in this, and it's just been amazing to watch. And thanks so much for sharing it with us and spending time with us this morning.
Thank you
Thank you so
all.
much, Professor. Thank you
Thanks
so
so
much.
much.